Hi, good afternoon, everyone. Welcome to the June 25th session of the Virtual Learning Collaborative, overview of the Hepatitis B and C lab result interpretation resource made possible in partnership with the CDC Division of Viral Hepatitis. My name is Zakia Grubbs. I'm a manager here on the hepatitis team. For today's session, we will have presentations from Eman, Addish, and Sarah New, who are HepTAC Advisory Committee members, followed by a moderated discussion led by Heather Wingate, our Hepatitis Advisory Committee member. So feel free to use the chat to introduce yourselves and your jurisdictions, and if you have any questions. Next slide, please. Following this session of the VLC, and also the previous VLC we had a month ago about the care cascades, we will be offering office hours for you all to join at your convenience to have a chance to talk with our consultants that are presenting today about care cascades and interpreting labs. So as you all can see, we will be meeting on July 21st and July 28th at 3 p.m. Eastern time. And then the registration link, I just put that in the chat. Just to make sure we have enough time to go over all the questions and we have enough coverage for what you all need assistance with. Please feel free to email us at hepatitis@nastad.org with a brief description of what you would like to discuss ahead of the call. So yeah, we are looking forward to this. It should be exciting. And yeah, I guess we can turn it over to our presenters to start for today.
Awesome. Okay. Hi, everyone. Today, Sarah and I will be chatting to you about our lab interpretation resource that we've developed. Next slide, please. Awesome. So the agenda for today's presentation is we're going to start with some background along with the need, go through our methods of how we developed it, and then we're going to go through each of the steps of our guidance and applied steps, followed by sharing our resource and going over limitations and our takeaway at the end. Next slide, please. So many of us have seen hepatitis lab data that simply just says less than 15 international units per milliliter without a clear interpretation. It's hard to know how to classify those results, and this guidance was born from that gap. Our goal is to help teams not only recognize what's missing, but also work closely with informatics partners to fill those gaps. We'll walk through the technical aspects like the NTE segments and provide a blueprint for finding interpretation notes and incorporating them in your surveillance system. This isn't just about HL7 and coding, it's about collaboration, speaking a shared language with informatics staff, and ultimately using data to inform public health programs and to better identify individuals who need care if able to do so. Next slide, please.
Thanks. So in practice, we often receive quantitative RNA results without interpretation. For example, some electronic laboratory results report values like less than 15 international units per milliliter without qualitative results, like detected or not detected. When the interpretation is unclear due to missing information, I personally usually check the notes fields first for interpretive comments like the detected or not detected. If missing, I will then track down the lab specific guidance from major labs, if that's who's reporting the result, like Quest or ARUP or LabCorp. Or sometimes I'll use loink.org to identify test reference ranges based on loink codes. And then I will also review the full panel to examine all hepatitis-related results from the same time frame, looking for an accompanied qualitative result like not detected or detected to clarify the interpretation. So next slide, please. Sorry. So what we did to sort of quantify this problem is we looked into our data in California to see how many ambiguous RNA lab results we received. So between 2018 and 2024, we received almost 400,000 RNA results electronically. Among those, 46,446 were reported with a less than sign, of which 9.5% of those were missing qualitative information in one or more fields. So of the 4,418 RNA labs with a less than sign and no qualitative results in the results fields, I then looked in the notes, and 2,510 had no interpretive comments in the notes field. And then next I did my step where I looked for the qualitative panel. So of those, the hepatitis panel, and of those with no interpretive comments in the notes field, 1,881 had no qualitative results in the full panel. So that left 4% of ELRs with a less than sign as just uninterpretable. So the question here is, what do we do with these ambiguous results? Are these negatives? This is how we classify them in California. But misclassifying people could result in issues with our care cascade, or in our case, with our data to care line list, in which being viremic is required for linkage to care, which is, as you can see, problematic. Next slide. So I just wanted to take a minute and just poll the audience to see if this resonates with you. So have you ever received lab results with a less than sign and no additional information for clear interpretations? And then please select yes if you can relate, or no if you haven't seen these in your surveillance system before, or if you haven't seen the cat. This meme really made me laugh. So it sounds like most of you have had this experience, and so this is common. And if you haven't, I hope you're at least enjoying my selection of memes. All right, so I'll go ahead and, or can I end the poll? That's probably, yes, I can. So I'll go ahead and end the poll. So about 84% of you have had this problem and you can relate. So now we're going to really get into what we did to help everyone and support you in navigating this very frustrating issue. Next slide, please. So Eman and I decided to put together a guidance. Actually, I think Eman did, and I just jumped on to help her. But we decided to put together this guidance to help interpret these results. So to do so, we reviewed all chronic hepatitis B and C ELRs from Quest, LabCorp, and ARUP reported in our health jurisdictions between 2018 and 2024. And then we documented results from lab tests for each test type, including hepatitis C antibody, RNA, and genotype, and hepatitis B surface antigen, surface antibody, core antibody total, IgM, little e antigen, little e antibody, genotype, and DNA. We also cross-reference the results with available resources online and work directly with our informatics team, which is going to really be a key theme in this presentation. We also had the Division of Viral Hepatitis at CDC review this document, and currently the document is we sent it to the major labs, so we sent it to Quest, ARUP, and LabCorp, and we are having their quality assurance staff review the interpretations. Next slide. Now it looks like I'm going to hand it over to Eman to start getting into the guidance. Next slide, please.
Okay, so in the first step, if you don't have access to the raw HL7 feed, you will, or if you do have access, sorry, you'll open it, and I usually open my text files in Notepad++. And then to take a step back, HL7 is a standard way to structure messages so that healthcare systems, including laboratories, can exchange information, and in this case, transmit information to public health. The messages are transmitted electronically and can be parsed to be ingested into surveillance systems. However, if you don't have direct access to the HL7 messages, you can provide the informatics team with the individual's event ID or patient ID, as well as specimen collection date and test so that they can review the HL7 messages for the specific lab result that you're interested in. Next slide.
So I'll be taking us through sort of an applied example. So what you will be doing is reviewing the observation and results, or OBX, segments in the HL7 feed. So each OBX segment is just one piece of the results, like a lab result or clinical observation. And what these do is they make it possible to automatically interpret and organize data in health surveillance systems. And in our case, the relevant OBX segments are OBX5, which contains laboratory results, OBX6, which has a unit of measurement, OBX7, which has a reference range, OBX8, which has an abnormal flag. And then you can use HL7 version 2.5.1 ELR guide, page 104 plus, to explore additional segments. Honestly, if you just Google HL7 version 2.51 ELR guide, I was surprised and very impressed by our own system, because we actually had our own guidance around this, and I had no idea until I started looking into this myself. But a lot of health jurisdictions have already laid this out very well in documentation, and you can find that online, and it's so helpful when you're trying to read through these. And then you also can check the note or the NTE segment for interpretation comments like HCV RNA detected or HCV RNA not detected. Next slide, please. So before we continue, we also wanted to poll everyone to ask if you have had experience reading HL7 feeds. I personally have not. I feel like in California, we're very separate from our informatics group. We go through them for everything. When I think that Eman had a much different experience, possibly also coming through the informatics team was helpful for that too. But having direct access is something that was very foreign to me. So I actually learned a lot by putting this together with Eman about how to read them. And it sounds like from our poll, we have about 2/3 of people, so about 77% have not read HL7 feeds before, and 23% have. So our next slide will be a good introduction on how to do that. So next slide, please.
Okay, so I'm going to walk through an example of an HL7 feed. I'm going to start with the OBR segment, and I want to note that I did omit the PID portion of the feed, which would usually include the patient's information, and the message has also been stripped of any identifying information. So for the OBR segment, which is at the start, I first highlighted in green the OBR4 location, and the way to count this the line is you'll see these parallel line. I'm using lines a lot. Parallel lines. I can't put my cursor on it, but the number one that's after OBR is in the first spot of OBR. So that would be OBR1. And then after that, where it says, oh, perfect, someone has a cursor on it, would be the second portion of OBR. So that'd be OBR2. So the green highlighted section is OBR4, and that includes the lab test that was ordered along with the link information. When you see the caret, which is right after the 11011-4, which is the LOINC, that's the comment separator. So the LOINC would be OBR 4.1, and then after that, which is the test name, would be OBR 4.2. And then next in the yellow highlighted section is OBR 7, and this includes the observation date and time of when the specimen was collected. I have next highlighted in blue OBR 13, which is the location where the relevant clinical information is located, such as the pregnancy note. I would also like to draw your attention to OBR 16, which is the section highlighted in pink, and it includes the ordering provider information and their NPI. And the last OBR component that I wanted to mention is in in a dark yellow color, and it is OBR31, which can contain ICD-10 diagnosis codes. And for the OBX portion, I'm going to start with the green highlighted component, which is OBR3, and that includes the information about the lab test, similar to the green highlighted portion in OBR. And okay. And the next one is the blue highlighted section, which is OBX5, which Sarah mentioned previously, and that contains the result value. And in this case, we see a less than 12. It can sometimes contain the SNOMED as well, which would then be broken up with the caret, and you would see the SNOMED in 5.1 and the lab result observation in 5.2. The next highlighted portion is bright pink, and it is OBX6, which contains the lab units. And on this message, we see that it's the international units per milliliter. And the next highlighted section is in dark blue. You'll see that it's blank in our message, but that is OBX7, and it usually contains the reference range. And the next highlighted section right next to it in yellow is OBX8, which contains the abnormal flag. Usually you'll see an N for normal, A for abnormal, H for high, L for low. However, in this message, it is also blank. And that tells us that we're not able to truly interpret the less than 12 because we don't have the reference range or the abnormal flag. So if you look at the last two lines, there are the NTE lines. And the first one tells us less than 12, which is the same result in the OBX5 field, which was highlighted in bright blue. But the second NTE field tells us that the result is Hep C RNA not detected. And we can go to the next slide. Thank you. So this slide includes the OBR fields and the descriptions. The highlighted fields correspond with the highlighted portions on the previous slide. I believe you'll have access to the slide deck, which is why I included this on here. Next slide, please. And this slide includes the OBX fields and the corresponding description, and the highlighted fields correspond to the highlighted portion of the OBX segment on the example HL7 slide as well. Next slide. Okay, so once we've identified that the interpretation notes exist, the next step is to decide where they should live in your surveillance system. To do this, you'll have to work closely with your informatics team to identify or build a field that can hold this data in a way that aligns with your system structure and can be used for downstream analysis. And finally, when the interpretation notes aren't present at all in the feed, that's the time to loop in your lab partners. Your informatics staff can contact their technical contact at said lab and request the staff start sending those notes, ideally in a standard segment like the NTE field. This step ensures that we're not just identifying valuable context, but we're actually preserving it in the system in a way that's actionable to assist with case statusing. Next slide. So next, in step 3, the goal is to ensure that the additional interpretation notes are integrated into the HL7 messages or fully usable within your surveillance system. To do this, we're going to start by updating the system's code or configuration so that it can recognize and correctly process these notes. We want to make sure that the information is presented in a format that is easy for staff to review and interpret. This process can also be applied to other fields, such as capturing the reason for testing or identifying pregnancy status, especially when the information is reported in HL7. Next, it's important to validate that the changes are working as expected. We want to run code to confirm that notes appear to the right place and are correctly being linked to the lab results that they are referring to. Finally, we want to build in routine maintenance regularly to check that the notes continue to flow in the data feed and that the system updates or lab reporting changes haven't disrupted the process. If any new ambiguous values or formats appear, follow up with the lab for clarification and coordinate with your informatics team to update mapping as needed. This ensures your system stays responsive and reliable over time. Next slide, please. When the result notes were present in the HL7 message, we typically map them to the result comments field, which is associated with the lab tests. This mapping is usually handled by our informatics team. It makes it easier for staff to review cases that have been assigned to them on the front end. And when it comes to our EPI staff, they're able to also review those comments and apply them in their code when looking at test results along with the test so that they can create combinations like positive RNA test or negative RNA test. And when it comes to our quality assurance, I used to be in Philadelphia, so we had a Maven-based surveillance system, and we had an unknown queue in there that allowed us to identify data or routing issues that were occurring. And then if we noticed something was wrong, it would allow us to collaborate with our informatics team to ensure lab results are being reported correctly and to troubleshoot whether the appropriate notes are present to support accurate result interpretation. In addition, we maintained code that cleaned and processed individual results, which included built-in validation checks to ensure results are being interpreted appropriately based on our defined logic. Next slide, please.
So in step 4, we focus on what to do when interpretation notes are still missing and can't be mapped. So you want to start by documenting the gap. Note which labs are affected and what their ambiguous results typically mean. Then you want to work with your team to build logic that interprets these results, plus lab combinations such as positive or negatives based on known patterns in SAS or your preferred coding language. And then this helps ensure consistent interpretation and accurate surveillance, even when the full interpretation is not available. Next slide. So an applied example of this step is to first document known gaps, tracking labs and test types with missing or unclear interpretations. Of note, this may change over time as new tests come on the market and old tests are retired. That has actually already happened since we've made the guidance. So just be aware that, things are always changing. Next, you need to apply any lab-specific logic you already know. For example, using lab rules to classify results for, let's say, Quest labs as less than 15 international units per milliliter equals not detected. This would likely be done on the back end of your surveillance system using code because you couldn't map it and get it into the surveillance system itself. And then finally, you want to flag the remaining results for manual reviews since these could not be auto-classified. Unfortunately for these, you actually may be required to follow up directly with the laboratory results or with the laboratory that reported them for interpretive results or reference ranges. You can then create a lookup table for consistency, which should include the lab name, reported format, lab provided interpretation, and the surveillance interpretation. Eman has experience creating a lookup table if you have any follow-up questions. Next slide. And luckily, also, Eman and I have put together this guidance, which includes the lookup table for the major labs, that's Quest, ARUP, and LabCorp as a resource for you. And then you can actually just add to this guidance as you find maybe some of your smaller labs aren't sending that information and you need to add it. This is a really great place to start. And so this slide actually shows screenshots of what the lookup tables featuring Hep B and Hep C tabs with the look like in the guidance. And as you can see here, there are lab results, the test name, interpretations, and notes organized by the laboratories. And this is what I'm also in the process of having the labs also review to make sure that our interpretations are correct. And so far, it's been fine. Next slide. We also provide SAS and R code to accurately categorize results once interpretation notes are mapped. So these are really just generic codes. Eman's the SAS coder, I'm the R coder, but you should be able to adapt this to work with your ELR results on the back end and help with some of those uninterpretable results in the future. Next slide, please.
Okay, so there are limitations to the resource since it uses a specific labs such as LabCorp, Quest, and AREP. We did not include any smaller or local labs. And the lab formats also changed over time. For example, AREP started retiring some tests over the years, and LabCorp now reports less than 12 international units per milliliter, in addition to less than 15 international units per milliliter for their Hep C RNA. Which is why ongoing monitoring and updates are essential to maintain accuracy when interpreting results. Next slide.
So we hope that you're able to use this approach to improve case classification, clearance metrics, and linkage to care by providing guidance on how to handle ambiguous lab results. This document should also help improve your ability to understand and map your HL7 feeds to your data systems, which can improve the surveillance quality, data usability, and public health action. This guidance can also be applied to other fields like pregnancy status, as Eman showed you earlier in the HL7 feed, that can be associated with hepatitis labs. And finally, we hope this guidance can build strong collaboration between epidemiology and surveillance staff and informatics and laboratories, which is essential when utilizing clinical data for public health action. I also just want to add that this document is a living document as lab results do change over time. And we would be happy for feedback. This is, a live document. The purpose of us presenting this now is to get feedback from people on this call to see what is helpful, what might be missing, how can we support your activities, and by supplementing things into the guidance, just to help you all and ourselves actually in the future. Next slide. And I just wanted to say thank you to folks that helped us create this guidance and to help get it to where it is today. Next slide. Yeah, so now we will open it up for discussion and Q&A with the audience. I think, Heather, do you want to take over this portion or?
Yes, let me just stop sharing my screen so I can see the chat. And let me go to the chat. So feel free, if you have any questions, go ahead and raise your hand or drop your question in the chat, as well as any feedback. Please go ahead and also provide that.
Did we send out the guidance with the meeting reminder too? Didn't it get distributed that way as well?
Yes, it's in the invite, but it's also a link to SharePoint. Once we finalize it, then we'll put it on our website and it'll have broader access. But for now, it's just on SharePoint.
Perfect. So I do see the first question comes in from Rebecca George. It came in at 2:28, so I'm not sure what we were referring to. You said, will we be able to access that? Would you mind coming off on mute to clarify what access?
Hi, yeah, it was the document with the test names and interpretations.
Yes, I believe if you don't have access, you can email Zakia as well. I think she dropped the link in the chat.
Yes,
It's
I'm
currently on the
emailing her
SharePoint.
right now.
Okay, perfect.
Thank you so much.
Perfect. And on in relation to that, will this document continue to be updated in the SharePoint site? And if people have feedback based on those 3 labs, who should they send them to? So like if they receive a new result from ERA.
I think our hope is that it is a living document so that it can continuously be updated, because even when we were doing the process of looking at our historical labs, we noticed that certain results have changed, certain thresholds have changed, or the assays that they're offering. So we ideally do want it. I don't know if there needs to be like a tracking system when something has been updated, or additional note field of when it was included and who updated it, in case folks have questions.
And I
Thanks,
would
Eman.
add, there's a folder on SharePoint where this resource is. You all have access, or for the most part, you all have access to SharePoint, and you're able to upload documents to that folder as well. So updates, and if you all have updates from labs, or if you hear from your local labs at maybe like state level or regional, feel free to upload that information to the SharePoint.
Thanks, Akia. So the next comment is from Ray McLean. So my recollection from a long time ago was that some of the lab tests are not validated or FDA approved to yield an accompanying qualitative result. Has that come up in your conversations with your lab so far?
No,
Not
oh,
Go
go
ahead.
ahead. I was gonna say, I mean, I answered it in the chat, so maybe Eman, you could add your insight.
Not within the big 3 that we incorporated. Yeah, because they all have a qualitative with their quants.
Okay, that's nice. Sometimes we only receive, it's rare nowadays, but back a few years ago, we were receiving a lot of quants, like less than, with absolutely no interpretation or associated qualitative. Luckily, it's improved along the way.
I guess sorry, Heather.
Yeah,
I
no,
guess
go
I would
ahead.
say that it's in the NTE field. So it's something that you might not see right away, which is why we went looking in our HL7 to identify where it was so that it could be mapped into our registry. There are labs now. There's a couple where they'll send it in 3 different lines, and the quant won't have any interpretation, but the qualitative won't have any interpretation, but the quantitative will come in separately and will be the response on how to interpret the less than 12 results. So it's gotten a little trickier and has had some like coding. I've had to do some coding to basically ignore the less than 12s for specific labs and to only look at their detected or not detected results. And they come in like a panel of 3 results.
Interesting. So the way that you guys said in the presentation, for the most part in general, if you have a lab that's reported qualitative, quantitative, same day, qualitative's positive, quantitative's negative, do you usually just default to the positive, or are there situations where you would default to the negative?
Usually the quant does not have an interpretation, and
Okay.
the qualitative result will say that it's positive, or it'll say that it's negative. That's what I've ran into.
Okay. Same with you. Okay, interesting. All right, so our next question is from Clarice. Any plans to add more labs? Still recommend using this resource for results that come in from other labs. So 2-part question.
Eman, I don't know if you want to take it or not. I mean, the big thing I think that Eman and I were working on, the reason that we chose these labs is just because they're the big ones. I think sort of when you get outside of these major labs, you start getting into like regional areas and or smaller labs, which can also be equally as problematic sometimes. So I think at that point, we could still continue to use it and add. I mean, people find stuff, especially on the regional labs. Yeah, we should probably continue to add to it. It would be wonderful to have it as inclusive as possible. But yeah, I think the issue is like I think what was it? It was an AREP that I had to look up for you, Eman, because they're not a big reporter for her. So that was like an example of something that I had to do on our end versus what Eman saw in their system. And so, yeah, I think the goal is just to continue to make it inclusive. And that really actually takes the power of many. It can't just be me and Eman that fill out the document either.
Yeah, that's a great point. Anything to add, Aman?
I agree. And I saw Ray added Mayo Clinic, and I agree with Mayo. However, they have stopped reporting to us because we just don't have a lot of sites that send out to them because a lot of our hospital labs have become a lot more inclusive and do the full hepatitis panel. So there's no need for them to send it out.
All right, great point. The next comment or question comes from Emily. How could this be applied with a newer point of care HCV RNA test result, which is a qualitative readout?
I'm gonna let you take that one, Eman. I do not have an answer for that.
A part of me thinks qualitative readouts are easier. So it would just be adding, I guess, the brand. I'm not familiar with the point of care testing if there's multiple brands, but I guess the company or the brand or the type of cartridges used and how to read the results. And just it would just be an addition to the document. So I feel like it'd be easier.
Yeah, I mean that was the thing about even making this resource document is like going through all the ones that weren't quantitative and they were qualitative. It was very easy to put it together because they were very standardized. It was detected, not detected. Antibodies were reactive, not reactive. And then you have sort of the in the middle, like non-quantitative results. Or quantitative, whatever, and the weird results which require retesting. And so those were much easier than anything that had a number on it.
Great point. Any other questions? Feel free to raise your hand or drop them in the chat. I have one that I have a question from Tennessee. So currently, well, Tennessee, we don't have access to HL7 messages. We rely on our informatics team heavily, and they're wonderful. But for our lab interpretation code, we don't look at the lab facility when we're coding our results as positive or negative. Do you guys, when you're pulling from the back end, and is there benefits to being more lab specific versus just being more general and relying on reporting of reference ranges and interpretations?
I haven't had to do it much, but the few times that I've done it is when a smaller lab where they're not able to give us or get the interpretation into the HL7. So they'll just verbally tell us that if it is a less than, because I had someone who said if it's a less than 15 and there's no notes, it's considered not detected. But if it's a less than 15 detected, they'll have the detected written in. So that was just an easy thing to code in my in SAS, looking at that specific or the laboratory and saying if the result is this, it's considered not detected.
Yeah, I think we have used facility name before. It's a mess, like everything else is with hepatitis C. So it's something we're not used to, I guess. But I think, in this case, it does give you we do use it and it gives you some, I like it will give you some trends or show you some patterns that might come up by using it. So I think maybe it's worth keeping in and looking at, even though it can be messy. I even think one of our EPIs tried to clean it up a little bit as well. So that's another pain point, but could be beneficial in the long run.
Yeah, no, agree. I think we utilize the NED space system, And the way our lab, you can kind of report a lab in 3 different places. You have like in this drop down menu, which is lovely. It's, detected, positive, not detected. And then you have a numeric field. And then you have a free text field, which we try to look at the free text field last, just because it's like such a mess. Like sometimes it will be a paragraph about what on earth happened to the specimen from collection to
Yeah.
testing. And that can be quite difficult.
Especially if
Yeah.
they put the reference range in there, and then you want to make sure you're not mining that instead.
Yeah. I think the way that I've coded it out in the past is I basically look for the NTE and then I look at whatever's directly after that line. And then usually it's right there. And honestly, I don't trust a whole lot other than that, because then you start picking up on a lot of just noise or real true results. You just aren't able to decipher them.
Yeah, great point. I feel like we just do the best we can. So I'm not seeing any more comments in the chat. Do you guys have any questions for the group? Do you guys want any feedback on anything?
Oh, for sure. I think if anyone sees a result that they've been receiving that's not on there, definitely add it to the Excel sheet. I think.
Yeah, I was even wondering if we should add an extra page just so people can like ask questions or make comments too. Like again, it's a living document. And I think really one of the takeaways that I've learned throughout this whole thing is just how closely I think in a perfect world, we all would have had our informatics teams on this call. Like that is like the key piece, especially if we're in places that our informatics teams are so separate from us. Because I think there's a shared language that I just learned by making this guidance that was really helpful. And so I could actually talk to them a little bit better. Now I understand also some of the actually complete barriers, like things I'll probably never get into the results fields, and actually why. So I'm not like, asking all these questions that have, that are literally are technical barriers that you just cannot overcome. And so now I kind of have a better idea of how to overcome them on my back end, because we really can't do anything about it. And my informatics team can't do anything about it. So I accepted that.
No, that's a great point. I like that you guys walk through an HL7 message, because when we meet with our informatics team, I don't speak the informatics language, and they try to like, I don't know, dumb it down for me, it feels like. And so that was good, because to me, I've never seen HL7 message. So I'm just like, I just need this in NBS so I can pull from the backend table. And so it's hard to be able to discuss when we don't really know how they're doing it. Okay, we have a couple more questions that just came in. So Chloe says Hep B next, and then Eman, you did respond. It's on there.
Yeah, we have a Hep B tab as well. So you can toggle between both, but we did include LabCorp request and AREP for the Hep B panel.
Perfect. And then our next question is from Adam. Have you had any experience in handling combinations of qual and quant results being read into the surveillance system as separate conflicting results, such as less than 15 not detected being reported with run result that is less than 15 and interpreted as positive, as well as separate not detected result being interpreted as negative?
So the less than 15 being interpreted as a positive, is that because there was a detected note with it, or?
Adam, are you able to come off of mute and clarify? Or post in the chat? No, he's trying.
Okay. Oh no. I guess I've had a lab that hasn't done something quite like this. It's kind of been the less than 15 with no information and then the not detected by itself. When I've noticed those like 2 or 3 labs coming in like that, just start coding it so that in SAS, it'll ignore the results that are just quant, and we'll look at the qualitative result. Because a few of the labs have said default to our qualitative results. Or sorry, yeah, qualitative.
Yeah. Yeah. I think we see this more often because we are just blanket coding all of those less than some number without a qualitative result as negative. And then there will be a positive quant. So it's more of a R error than the panel error. But honestly, like I've worked with these ELRs for so long that I'm sure that's in there somewhere. Like it just is guaranteed to have presented itself at some point. But I have not come across it, probably because I have not systematically looked for it. I've turned a blind eye, I think.
All right, then Monique did comment on Adam's question. For Indiana in our interpretation code, when there is a set of results that have a qual and quant result on separate rows for the same lab collection report date, we group and then use a fill function to pull the interpretation down to the numeric result. So interesting. So essentially you're filtering, you're adding the qualitative interpretation to the numeric lab.
Mm-hmm.
Yeah, you're basically defaulting to the qualitative lab, which is likely what I would do as well.
Mm-hmm.
Because I, at least in Tennessee, like I don't believe I've ever seen where the qualitative lab was negative and then the numeric was positive. Because typically they're only doing the numeric and sending us that if there's a reason to run a numeric test. So interesting. Okay, so Alan asks, is there an ask for laboratories that would make interpretation easier? If so, we could take the ask to one of the CSE ELR committees and ask them to disseminate.
That would be amazing.
Yeah. Yeah, I think we could probably talk about that offline and see what our actual ask is, especially after toiling through these for so long.
Yeah, it'd be great to get the viral hepatitis and informatics folks to work even closer. Luckily for us, one of our informatics people is pretty familiar with viral hepatitis and came on in the last few years. So that's been nice. But yeah, it'd be great if there could be more collaboration between the groups. All right, and then Kaylin made a comment in, oh gosh, WI, Wisconsin. I'm horrible with states. This is so bad. In Wisconsin, we got different guidance years ago from our informatics state lab, and they said to count all less than labs as negative. Is there a reason that you are counting the detected ones even if the viral load is listed as less than?
Because when you call the labs, because you said you're a state lab, but when you call LabCorp request, they'll tell you it's detected, it's a positive. They just can't quantify it.
Yeah, it has to do with the lower limit of quantification. It's either above that or below that, and then that impacts whether it's detected or not detected. And there's guidance that I pull up all the time. There's like 3 documents, the hepatitis related, that I pull up all the time. And one of those is the APHL guidance around hepatitis C results that are below the lower limit of quantification. And I think that kind of gets to what you're speaking of, Kaylin. And I can drop that in the chat too.
Yeah, and I would say we always like default to, the detected versus the non-detected on the same day, because it really heavily impacts our care cascades, because just that one negative triggers like us to count them as a reinfection. So it kind of like artificially inflates our reinfection, which is why like we just consider them to still have the virus, just at undetectable levels. And then we'll hope to get future RNA that's negative, and then we can go ahead and call them cleared or cured. But it caused a lot of false reinfections. Okay, Adam put in the chat, it may have been specific error within our surveillance system reading all numerics as detected. We had since implemented fixes, but they're specific to each reporting labs versus a broad remedy that would be more ideal. So thank you all for all the insight. I wonder if you use the NEDSpace system, because for us, our workflow decision support, they can't read numeric sign. They can't read signs. So they can't read greater or less or equal. So anytime a numeric result comes in with any of those, it's unreadable. And so they can't classify it, which is quite annoying. I was on the long list of
Hey.
NBS fixes.
Finally figured out the mute.
Oh, there you go.
Hey,
Hey,
thank
Adam.
you for the response. That very well could be. Our surveillance system is homegrown too, so it may not have like broad guidelines, such as that might occur with like more commercial surveillance systems. So that could be a problem. Yeah, but same issues with our peer cascade interpreting results that would be positive and negative on the same day. Kind of threw a wrench in things sometimes, but what we ended up doing was calling individual labs and finding out if these are interpreted as detected or not detected, and then created just an internal reference sheet, and then implemented algorithms in our surveillance system to handle each individual reporting lab. So not ideal, but we have a current fix. Was just curious if anybody else had gone through that. Thanks.
I think that's a really good example too of like, if, it sounds like that as a lab that probably regional, but if not, or like, like local, but if it's ends up being regional or larger, like that's the kind of stuff that we would want to add on to this list, for example, because what we realize is that we're all doing it in different ways. Like people have built in these back-end codes to like capture some of this stuff. And, it's just breaking down silos, right? We're trying to start sharing all that information because we're all having the same problem, like when it was 84% of us have dealt with this. And so if you have, you being the person listening or watching, has that come up again, and actually, even if you don't know if they're in other states or not, then you can just add that to the documentation, and so that we can share that information, because it's just supporting each other and not having to work in this vacuum of crazy ELRs by yourself.
Yeah, great point, Sarah. So I'm not seeing any more questions in the chat. So I'll pause if there's any lingering, and then I'll turn it over to Sakia and then to close this out.
Just going to try to verbalize my question because I'm having a hard time even formulating it. But we definitely run into problem most commonly with hepatitis B DNA results, getting just reported less than 10 and not having the additional information about whether it's detected or not detected. And another issue that we're running into is that our surveillance system, we're using EpiTrax. We've been told that we can't really change things by lab, that it could only interpret things kind of universally. I guess, do you have any, again, I'm not exactly sure what my question is here, but do you have any recommendations for kind of how to deal with that, how to deal with that constraint?
Is it a specific lab that's doing this, or?
It seems like we're getting it from a lot of different labs,
Okay.
where we'll just get less than 10. And then we don't know whether to, right now we have it set up to call all of those equivocal, and then we do further investigation into the results because we don't know if that means less than 10 detected, less than 10 not detected.
I would reach out to your informatics group. It's probably in the HL7 message in the NTE field we showed you, or possibly somewhere else, and see if they can either provide that to you through a SAS table or an XCSV that you can then like link to your system if they can't get it into EpiTrax, since you said it seemed like it was difficult to create new fields, but if you're able to create a new field, I would, and then see if they can map it there instead so that you can see it on the front end and also be able to pull the data out on the back end.
Thank you.
Because we've had that, and I think Quest does that from one of the Quest labs does that for us, our local one. And they send the detected and not detected as a separate result in addition to the less than 10. So I'd make sure that if it's in there, that it's fully being adjusted into a system as well.
All right, thanks, Eman. We're about 2 minutes close to time, so I'll turn it over to Zakia. Are you closing us out?
Yeah, we have one more comment, question in the chat from Alan.
Oh, I missed it because I started sharing my screen. Okay, hold on. Okay, I wonder if a lot of labs do not even know that their data is being used for this purpose. But I'd be curious if others even understand that these results are being used for measuring clearance this way. Yeah.
That was why I thought, so there was a session at CSC where we were kind of talking similarly about some of these issues with reinfection, and actually a LabCorp representative was there, and I was surprised because I feel like they usually are very disconnected. Maybe in some of that follow-up back with them, you know, they or maybe some of this like then cross-checking our guidance and stuff is open that door a little bit, but you know, it's still just like one person in the big conglomerate of these laboratories. So yeah, I'm sure they have no idea how big of a problem it can be on the flip side of surveillance systems.
All right, and then there's just one last comment from Monique. There are certain test labs where when I have called the lab, they say that the specific method of testing they use does not have a differentiation of detected and not detected, and the test is specifically meant for testing only in patients that have a confirmed infection. They get frustrated with me asking for an interpretation of the lesson result.
Yeah, yeah, thank you all so much. This has been a really great session. I appreciate all the comments and the questions in the chat, and also our wonderful presenters and moderators for walking through the resource and seeing how we can all come to collaborate to have a much bigger environment that support work with. Time, this is unstable, so hopefully y'all can hear me. But yes, please email us ahead of time with a brief description of what you all would like to discuss during office hours, just to make sure we have enough time and that we can answer all of your questions. So yeah, thank you. Hopefully y'all be able to join us for office hours, and hopefully you all will be able to work with us to collaborate on this resource. So yeah, the link to the SharePoint for the document is in the chat. So hopefully y'all will be able to go in there and add all of your lab information. And if you all have any comments or questions about anything in the guidance document, let us know. All right, well, thank you all so much. It's been a really great session. Thank you so much. You all have a good rest of your afternoon, and yeah, we'll see you all soon. Thank you.